you wrote a paper with regards to sort of the diagnostics of MCAS. Maybe you can sort of now just explain exactly what it is. People are in now saying, hang on, I might be inflamed. I've got MCAS. What do I need to do? How do I diagnose it? And what can I do about it? So maybe unpack the diagnostics.
Yeah, I think this is really the most difficult thing. So first and foremost is you have to get the history. You really have to, understand from the practitioner's perspective, but even people who are listening, who are thinking this, right? Thinking about their life and the different events that happen over the course of their lifetime can be helpful in understanding whether this is potentially a diagnosis. Again, usually patients with MCAS have an escalation of symptoms with various triggers over time. And it does usually start fairly young. However, you brought up the story of all of a sudden reacting to garlic, in your 40s when you never had any issue before. There can be triggers later in life that could bring it out. Okay.
Yeah.
But generally, the vast majority of patients have some susceptibility to it at a younger age. They may not have food intolerances. They may have some other manifestation. This is an inflammatory multi-system disorder. So it could certainly be that they have migraines. They don't have a problem with food. They have migraines, or they have um, episodes of hypoglycemia. Again, bringing in the insulin resistance. They have, maybe they have. I'm trying to think of other, like, my gosh, because mast cells can affect everywhere in the body. So, like maybe a kid has ADHD, or maybe anxiety, or and so, but no problem with food, apparently, right? I will argue that there probably is a problem with food, but not an obvious reaction to the food, right? So you have this sort of flavor maybe that's going on, and then there are these various events, various triggers, sometimes obvious, sometimes not obvious, that bring it out, right? So I think that the history piece of this is just critical, because the data it's just not a perfect science yet. We can do blood work, we can do urine, we do random urine, we do 24-hour urine. We're looking for the mediators, the things that the mast cells are releasing. So we know that mast cells can release histamine, so we'll look for histamine. For some people, histamine is actually not one of the major mediators that causes their inflammatory process. It's
Wow.
something else. So we look for these other things too. But a lot of these are very thermolabile, so they're very sensitive to heat. Everything has to be kept cold. Everything has to be processed a certain way. So, sometimes it's hard to get the data through the
Yeah.
lab. Sometimes we have patients, because they've had a lot of GI issues. They've had, let's say, endoscopies or colonoscopies. If they've had biopsies, we can stain those biopsies and look for mast cells. And if there are more mast cells in an area, that can be diagnostic for mast cell activation syndrome. So we try to get 2 points of laboratory evidence, um, for the diagnosis. But it doesn't mean that we shouldn't be treating anyway. So I think if there's a good clinical history, I really like to push for the diagnosis as much as possible. Maybe we have to check labs a couple of times, maybe more, see if we could really nail down the diagnosis. Just opens up other things to use for treatment. But the clinical manifestations, the clinical, picture is really critical, right? So if you
Yeah.
have the story, and you have some pieces of information, but not the full thing, right? I still
Yeah.
would argue that that patient probably should be treated, or at least trialed on some of the easy things.
Sure.
And then the treatment part is complicated, but there's some simple rules and tools that we use.
I'm going to
Um,
jump in there now from just taking labs, and let's look at essential fatty acids,
yeah.
maybe amino acid testing. But from labs, are you looking at obviously the HSCRP, IL-6, IL-10? Are you looking at oxidative sort of stress points on thyroid function, T3 to reverse T3? What are we looking at from an inflammatory basic point of view?
Oh, yeah. Well, there's the mast cell piece. We're looking just for the mediators. That's
Yeah.
one. And then, yes, I'm casting a wider net because I understand that the mast cells are reacting, and there's a downstream effect from the mast cell that I'm looking at. I'm looking at all those inflammatory markers, but I also understand that there's an upstream effect. There's something potentially driving those mast cells to become more reactive. And so we have to look at all those pieces. So hormone function, thyroid function, HSCRP, all these things are really important. I've started to test more things like fibrinogen and measures of like D-dimers, things to understand a little bit about blood clotting, antiphospholipid antibodies, and for antiphospholipid antibody syndrome. I look at lots of antibody testing, and insulin resistance. So I'm looking at insulin, I'm
Yeah.
looking at lipids, I'm looking at apolipoprotein B, and I'm sure there's more, but
Yeah.
it's a big picture. And then I'm also looking at the like true root causes. So I'm
Mm.
looking for mold and
Okay.
mold toxicity. I'm looking for mycotoxins, which is a big trigger for many patients. Sometimes we do food sensitivity testing, but often it's not. If it's a mast cell problem, it's not very reliable. So I've started to do that much less. Stool testing, very, very helpful.
Mm.
Understanding the microbiome, understanding the digestive process, I think can help. And then the area of the country that I live in and work in, we have tick-borne, vector-borne infections and endemic here. Well, it's everywhere. It's all over the world. But I will, if I think the history is such that it's possible that they have an infection, then I do a deep dive there to try to see if that's a potential trigger for them.